Our next presenter today is Richard Lewis, MD. Dr. Lewis is with Cedars-Sinai here in LA. He is a professor of neurology, a director of the EMG laboratory, and co-director of the Neuromuscular Clinic. Dr. Lewis is board certified in neurology, electrodiagnostic, and psychiatric medicine. He earned his medical degree at the Medical College of Virginia in Richmond. So please welcome Dr. Lewis.
Great. Thank you very much. It's nice to be here. I realized when I looked at my slides I have more than we're going to be able to get through in 25 minutes or so. But nicely, as a tag team with Todd, he's touched on a fair bit of what I was going to say. So hopefully we can get through this and it'll be useful to you. So I don't know how many of you have been here before, but I have done this before here. Dominic seems to like repeat performance, so it'll still be a little bit different, and hopefully it'll still be useful. Most people don't remember anything I say anyway, particularly my children, but that's another story. Okay, so what we're going to talk about a little bit really has to do with our communication. And we're going to touch on going through the process of making the diagnosis. Someone just asked about, how long does it take to be diagnosed? It kind of depends on who you see first. But if you say you have numbness in your feet, most doctors, even your family practice doctor, who doesn't see as much neuropathy as I do, would probably recognize that there's something wrong with your nerves. If you have pain in your feet, there becomes a whole nother process. Plantar fasciitis, do you have arthritis? And people think about that. I want to reiterate what Dr. Levine said. If you have burning pains in your feet, it's almost never your back. And yet I can't tell you how many patients have already had back surgery for that problem when they get to me. So I'm probably preaching to people already diagnosed, but if you have friends who start saying, I'm having back surgery for my burning feet, say, get another opinion. Because it's one thing to have pain down your leg in one side and you have sciatica, that could be from your back. But both feet being burning at night is not from your back. So we're going to talk a little bit about this, and I want to talk, as you talk to your doctors, making sure that you and your doctor are speaking the same language. We'll talk a little bit about the treatment, treatable neuropathies, and some of the testing and what it all means and why we're doing it. So you go to the doctor and the doc asks you a whole bunch of questions and you start talking, and some people talk a lot and some people talk a little. Sometimes your doctors let you talk and sometimes they interrupt you and you think they're rude. I probably fit in that category, but we're trying to focus on what kind of symptoms that tell us what's going on with you. So there are many things that we need to know. We need to know when the disorder started. So when I ask that question, the first response is, it got really bad in the last year. Well, I didn't ask that. I actually asked, when did it start? Because if it started a month ago, it means one thing. If it started 10 years ago, it's a whole different concept. And so sometimes we want to know when it starts. I do want to know when it got bad, but I do want to know when it started because it's crucial to understanding your disease to know when it started. If it started when you're a teenager, probably have an inherited neuropathy. If it started 5 years ago and you're 70 years old, we're looking at more acquired disorders. Then we want to know, did it change? Did it progress? And what we mean by progress is also different than what you mean by progress. Your concept of progression is, my pain got worse. My thought on that is maybe that's not progression of the disease, and maybe progression of your pain. But if your numbness and pain went up from your toes to your ankles to your knees, that means that your nerves are getting more damaged in more places. That's the progression of the neuropathy. So sometimes we have to kind of determine what we're saying here. Some people, for instance, after you've had a chemotherapy agent and developed neuropathy, that happens pretty much time linked to when you got the chemotherapy. It may progress for a couple months afterwards, and then it doesn't get worse because the chemotherapy really was a toxic damage to the nerve, leaves you with the problem, and your pain can fluctuate. It can get worse, it can get better, but the disease actually was monophasic, meaning one phase. Guillain-Barré syndrome, that acute post-infectious neuropathy that can paralyze people, put them on ventilators, is monophasic. From the time you get the first symptom to the time you get your worst symptom is 2 to 3 weeks. It leaves people with problems. It takes months and sometimes years to improve. And fortunately, most people do improve, but not everyone. But it's a monophasic illness. The disease stopped at the 3-week point. Your damage persisted for a number of years. Many patients I see have had this Guillain-Barré syndrome but are still being treated for the disease, usually with intravenous immunoglobulin, because it hasn't completely gotten better. That IVIG has no benefit in that circumstance. So there is a chronic form of Guillain-Barré called CIDP, chronic inflammatory demyelinating polyneuropathy. That does respond to IVIG, and that does require long-term treatment. But Guillain-Barré syndrome that does not get better quickly doesn't mean it's CIDP. So monophasic illness, and some disorders go up and down. Then we want to also know location. Where did it start? Did it start in your toes? If it starts in your toes and creeps up, it's what we call length-dependent neuropathy. The length is the longest nerves in your body come from your spinal cord all the way down to your toes, or actually from the nerve cells which are just outside the spinal cord or nerve roots. But those are 2 to 3 feet long. And the longest nerves are more likely to get damaged than the shorter nerves. And so getting this pattern of progression is helpful. So then we ask, what are your symptoms? And this is also, Dr. Levine talked about the autonomic. I'm not going to go into that. But numbness. What you mean by numbness and I mean by numbness is not always the same. Some patients will tell me they're numb, and what they're really trying to tell me is my feet don't move well. My toes are stiff and don't move. Well, that may not be numbness. That may be weakness or stiffness. Numbness to a neurologist usually also includes pins and needles sensations, stinging, some alteration of sensation. So sometimes we don't ask the question correctly, and sometimes you are very concrete about what numbness is. Oh, I feel everything, so I'm not numb. But is it altered? So sometimes we need to have a little discussion about what numbness means. So I've used this slide before, a little bit different, but so this this cool hand Luke, most of us are in the audience or those who saw the movie. There are some younger people who should see the movie because it's kind of a fun movie. But this was a very famous quote in the movie about we have a failure to communicate, and I do think this is part of the issue. And I talked a little bit about some of this before. Here are a few other communication mismatches. And I do want to bring up the third point here. I don't know if here, this one here that Dr. Levine also brought up. A while ago, I realized that that probably is the most important question that any patient with neuropathy has. And that is, will I be able to walk the rest of my life? How many of you actually asked that question to your doctor? Very few. People don't ask it. And your doctors aren't always smart enough to know that's your first question. So one of the things you have to do is tap into your own fears. Listen to yourself and say, that really is the thing that's scaring the hell out of me. Ask it if your doctor doesn't bring it up. Because 90% of the time, you're going to walk the rest of your life. Okay? Now, there's caveats. Does it mean that I'm not going to use a cane? Well, if you're 60 and I can't guarantee you're not going to need a cane when you're 90, But the fact is, you should still be able to be on your feet related to the neuropathy in most instances. So whether it's that fear or any other fear, you have to be able to know what your concerns are and make sure it's addressed in the meeting. Most of you want to tell me, make sure that I know how miserable you are. Okay. I get it. It is terrible to have neuropathic pain. It's terrible to have any disease, but neuropathic pain is awful. I get it. I do want to know that, but I also need to understand how this disease evolved. So I keep coming back to, I got it. You're really in a lot of pain now, but how did this happen? You're also impatient. You're patients, but you're an impatient patient. And I don't blame you. The problem is we doctors don't have the quick fix. I wish we did, but we don't usually. And so there's a discussion that needs to be made about how long it's going to take for these medications to work. What should you expect? How do we know as a doctor and you as a patient whether the medication is beginning to work? And so you need to kind of have that discussion. You should always know with any disease, when they give you a medicine, what you should expect, and you need to know what the doctor is expecting. For instance, with treatment for the inflammatory neuropathies, the Guillain-Barrés and CIDP, let's say CIDP, I know that I'm not going to get people out of their braces or AFOs in the first few months of treatment. That will be the last thing that gets better, if it gets better at all. What I'm looking for in the first few months is the medication working at all. So I'm looking to find the marker that says, oh yeah, this is really working, let's persist. What are some of those markers? The not so weak muscles, but a little weak, if they've gotten completely strong, that's a good sign. If you tell me I can do some functions that I couldn't do before, that's a good sign. And we have some testing we do in the office to try to sort that out. But so just recognize the things that you really want cured are usually the last thing to get better. Because for you, the most severe things are the things that bother you. We know that those are going to be the last things to get better. Other fears and other issues. I frequently talk about the benefits of braces and ankle-foot orthoses for people who have weak ankles. Some patients don't want it. Teenagers, with my inherited neuropathy patients and Charcot-Marie tooth disease, they frequently need braces. Teenagers don't want to wear them. Teenage girls definitely don't want to wear them. And we have to go through this process of how do we do it? And sometimes there are compromises that need to be made. You wear slacks more when you're going to the prom. Maybe you don't wear them as much, but you have your partner's arm to hold on to, so that maybe you can do fine without it. Or you just say, get over it, people. I have this problem, and I'm proud of being able to do what I need to do and live my life. So these are also discussions that need to be made. So some other mismatches, I think I talked about this. Difference between cures and control. Most of medicine controls diseases, doesn't cure them. Surgeons think they cure diseases, and if you have appendicitis, they take out your appendix, and yeah, they've cured you of your appendicitis. But most medicine, no one cures your hypertension, they control it. Most people aren't cured of diabetes, you're controlling it. Same thing with neuropathic pain and neuropathy and other disorders. So the other mismatch here is fatigue and weakness. This is a tough one. Patients frequently talk about how fatigued they get and equate that with weakness. As neurologists, weakness means your muscles aren't working right. You actually have physical weakness that we can demonstrate. Fatigue is a very funny process. It's hard to discuss it. Are we talking about sleepiness? Are we talking about your muscles getting tired where they're collapsing on you, which could happen in your legs from lumbar spinal stenosis? It can happen in your eyes and arms if you have myasthenia gravis. or you can just get exhausted, meaning you just physically pooped. Cancer fatigue is frequently this global exhaustion that occurs either related to the cancer or sometimes to the treatments. So sometimes we have to define those terms. So we keep asking questions. We ask about the family history. We need to know everything. And I frequently have patients say, after I keep asking these questions, they keep saying, well, that's not relevant to my disorder. Let me decide. Sometimes, most of the time you're right, but sometimes, like all those vitamins you take, maybe too much vitamin B6 is part of your problem. You may not think of it. That's the other part of it. Anything you put in your mouth that's not food is probably a medication, whether it's natural, whether it's over-the-counter, whether it's a food substitute, whether it's CoQ10, they're still medications. So we need to kind of understand what you're doing. More feet issues. Dr. Levine and I both seem to want to discuss you with ulcerated feet. My wife is a psychologist. She's more on the analytic side than the CBT side, but nevertheless, both are useful, but in different ways. But she actually had to bring one of her patients for me to do a neurologic exam, and a very disturbed person. But my wife came out of that and says, boy, you spend a lot of time on people's feet. And we do. Neuropathy doctors, probably more than anyone else, are looking at your feet, other than podiatrists, and because we're looking for, there are all kinds of signs, and many of your symptoms are in your feet. So we do tuning forks, and we move your toes around, and we stick you with pins, and we light touch you, and we do all kinds of weird stuff. But the reason we do that is because there are different nerve fibers that give you sensation. The large fibers, which are the ones that the nerve conduction test can test, do vibration and position sense primarily. The small fibers that the skin biopsies that Dr. Levine and his group read, and we can do with little punch biopsies, are the small unmyelinated fibers, and those are the ones that transmit pain signals and temperature signals. So as neurologists, we try to figure out, are the large fibers involved? Are the small fibers involved? Is it just sensory? Is it just motor? We like to hit and scratch. Neurologists need to have fun too. And so the reflexes are important because sometimes numbness and sensory symptoms are not coming from peripheral nerves, they're coming from the central nervous system, and Dr. Levine touched on that. The reflexes are usually excessively brisk if it's the brain or spinal cord problem, and they're usually lost and reduced if it's peripheral nerve, which is why we use the neuropathy docs have the big heavy hammers and sledgehammers that we slam you with to try to find your reflexes because they're hard to get. The stroke doctors take their fingers and tap your knees a little bit, and because usually they're brisk, it doesn't take much to stimulate them. And the scratching the bottom of the foot is looking for a sign that tells us whether the Babinski sign, if your toe goes up when we scratch the bottom of your foot, it means the central nervous system is involved. Infants have it as newborns, but we lose them and we gain them back if we have central nervous system problems. We look at atrophy, we look at how much, when you have motor involvement, the muscles lose some of their bulk, and we can touch base on that. So a little bit about this torture test, the EMG. It's safe, but we call them electric impulses, but you all know that they're shocks. And the fact is, it can be uncomfortable. If you're an electrician, I guarantee you will hate it. In fact, most of my electricians as patients tend to jump off the table before we even turn on the machine. They're just so sensitized to the electric shock concern. Needles and needles. If you don't like needles, you're not going to like the EMG needle. And there are most of the time, they're very thin needles. They're very sharp. They usually, when you prick the skin, it's usually not too painful, but there are some painful spots in the muscle, and some patients do have some discomfort. But it's a very safe test. Even if you're on blood thinners, you need to let the doctor know that you're on blood thinners, because we usually don't like to stick the needles in too deep, but superficial muscles we do fine with. If you have a pacemaker or any kind of defibrillator, you need to let your doctor know about that. The thing about EMG is that it is, as we talk about, it's an extension of the neurologic examination in history. So what we test is dependent on what you tell us is going on. And we sometimes change what we do or add to the study based on what we see with each nerve that we test and each muscle we test. So there's no one EMG that's correct, except mine, which is always correct, and Dr. Beydoun's, which is always, so sometimes we say we need to repeat them, in part because the other doctors didn't do the nerves we needed to see to make a full diagnosis. So what can the nerve conductions tell us? It tells us whether it's on one side or both sides. It can tell us whether the changes are just in the feet or is it elsewhere. It can tell us whether it's generalized, whether it's just one nerve or two nerves or multifocal. It can tell us whether it's just sensory, just motor, or both. It gives us some idea of severity. And then it talks about the axonal versus demyelinating. The axons are your wires. The myelin is your insulation. If you just damage the insulation or primarily damage the insulation, it's called demyelinating. And the way the nerve conductions tell us that is because the conductions go very slow. So a normal nerve conduction velocity, this is a relatively normal one, and I don't know if you can read this, but 55 meters per second. Meters a yard, so it tells us our signals are going up and down our body, 25, 30 times in a second. Very quick. That's how I can move my thumb instantaneously, because the signals get to my muscle from my brain incredibly quickly. If you have a demyelinating neuropathy, your conduction velocities can be 10 or 20 meters per second, half, 50%, 80% loss of conduction. And this one here, you can see there's all kinds of breakup of the response. It's a sign that the myelin is not right, and then starts talking about disorders like CIDP and the most common form of Charcot-Marie-Tooth disease, which is CMT1A. So, which now is getting where we may have clinical trials on that disorder. So this is kind of telling you the story about the myelin, and we'll keep moving on. The axonal ones are probably the most common ones. Those of you who have numbness in your feet, and that's primarily what you have, 95% of you probably have an axonal neuropathy. There are some demyelinating or myelin-related disorders that can cause that same symptom. Sometimes they're related to changes in your blood proteins called a paraprotein. The axonal ones tend to be less treatable, tend to also be less severe. It's the primary finding in diabetes, although there is some of this myelin issue in diabetes. And most of the nutritional, the chemotherapy neuropathies are axonal. The demyelinating ones tend to be more inflammatory immune, and as I mentioned, the most common form of inherited neuropathy. Charcot-Marie-Tooth disease, no, it's not a dental disorder, it's actually the most common genetic disorder of the nervous system, and one of the most common in medicine. So we talked a little bit about that. I'm going to stick it. Why do we stick you with needles? Because it tells us what's going on with the muscles. If your muscle is weak, the needle will tell us whether it's from nerve damage or primary muscle problems. It will tell us whether it's how severe it is and localizes it. The other thing is most of the nerve conductions we look at are to the feet and to the hands. And so if we want to know what's going on in your shoulders and your hip girdle, we need to stick the needles in those muscles because it's hard to do the nerve conductions to those muscles. Can be done. It's a little bit more painful. We try to avoid it. We talked about that. Nerve biopsies, we don't do them very often anymore. There's probably few reasons to do a nerve biopsy. Mostly is to find something in the nerve that you can't detect by the EMG and the clinical examination. So inflammation of the blood vessels, what's called vasculitis, is one of the reasons to do it. Some infiltrating disorders, cancer, and the reason the amyloid's in red is because that's treatable. And familial amyloid, which you don't need a nerve biopsy to do, there is now some treatments that are coming up, and the FDA is looking at those in the next few months. And so that's an exciting thing because it's a genetic disorder. And so we're going to be able to treat a genetic neuropathy for the first time, and it's quite exciting. Sometimes there are unique features, signatures. Temaculi, which stands for sausage shape, so that you get sausage-shaped swellings of the myelin in disorders. HMPP stands for hereditary neuropathy with liability to pressure palsies. It's easier to say HMPP, but you have to know what it means. It's pretty common. It's the flip side of the most common form of CMT, the CMT1A. CMT1A has an extra copy of a myelin protein called PMP22, peripheral myelin protein 22. HMPP is missing a copy, so it's a deletion of that gene. The symptoms of that is I cross my legs, my feet get numb too quickly. I go on an airplane, my feet get numb, or I have a foot drop, or I went to sleep and my wrist starts dropping. And if you have a lot of those symptoms, then you probably have a liability of pressure palsies. You can get wrist drops from drinking too much alcohol and sleeping wrong, and you can do that too. But if you're getting a lot of this, then it tends to be this HMPP. And so here are some pictures. Here's some amyloid deposition with a special stain. This one you can see there's a loss of fibers. This is normal. And there's also some changes in the myelin here. So the treatment, and then I'll end here. It's crucial that you and your doc are in sync on this. So have this discussion. Take some time and have your doctors explain to you what they're expecting to happen when they give you a drug or any treatment. Surgery, even more than that. What are you really going to fix? And because you don't really care what your back looks like, okay? What you care about is my pains in my legs or my weakness. Is that going to get better? So you need to get that figured out. All treatments we are doing in our head, risk, benefit. And the benefit better be better than the risk. The other issue here is, and I hear this all the time from patients, I don't want it, it can have side effects. Side effects aren't risks. A risk is I give you the medicine, you're going to die, okay? Maybe it's a risk, you're going to die, 1 in 100 are going to die, but it's a real risk. That's dangerous. Now, it's not a percentage-wise big risk, but if you're that 1 in 100, that's become a huge risk. A side effect is I take the medicine, it makes me sleepy, I don't like it, I stop it. If it's a side effect, give it a try. Everyone doesn't get the same side effects. Dr. Levine went into this. If everyone fell asleep on a medication, the FDA wouldn't approve it, okay? Because it doesn't happen. But if 2% of people get sleepy on gabapentin, okay, you tried it, try something else. So please, and then they'll say, I only want to do natural stuff. So then they take a gazillion things over the counter, and they'll have potential side effects from that. Those are medicines too. And to be honest with you, those medicines are unproven. The medicines that we're prescribing have some evidence that they work in some percentage of patients, usually enough to warrant its trial. Here we go. I won't take medicines, aren't there natural treatments? There are important things to do, and Dr. Levine touched on them. Improving sleep is crucial. No one is, if you're not sleeping, you're going to be in more pain. You have to deal with sleep. And I like the same kind of medications Dr. Levine talks about that can kill two birds with one stone, so to speak. The other part of it is all this mindfulness, meditation, all those things that are relaxants are good. They're healthy in many different ways, and it will help you reduce your pain. It's not going to get rid of it usually, but it will reduce it. So all those things are good. And on that note, I'm getting the yanker. So I will stop here and just be yanked. Thank you very much.